So these are groups, 9 groups spread across Barnet. They have been dominated by GPs mainly who come to the meetings, and we're wanting other professionals to come together. And the series we've held so far in autumn have been about end-of-life care, conversations and challenges about end-of-life care, and then working how we work together. We are mindful that you are very busy people and we are in a very resource-poor environment. So we don't want these meetings to be a talking shop. We actually are hoping that there's going to be some real impact as an outcome of these meetings. So I would like to summarise what we've done so far in the September and October meetings, and that will be a summary of your views, not CPEN's or ours. This is what you're saying about the challenges of end-of-life care. I'm mindful that we have people from CMC, the CCG and the Federation here, so I'm hoping that they're taking lots of notes and that they'll be ready to listen to not just the summary from September and October, but the outcome of this meeting. And already one outcome is we've got an end-of-life steering committee that is very dynamic. Jo Brady said it's so much fun, it's like going to a party. She's so excited about going to that meeting. So there's a dynamic steering group already that started as a result of this programme. Now, one overwhelming theme that you all said when you had these meetings was the issue about joint working, collaboration, and that's the only way forward. And when we talk about collaboration, inevitably the concept of a care plan comes, or an advanced care plan. So some people groan at the word care plan, and the things that you were saying was, you remembered the admission avoidance scheme that was time consuming, didn't really benefit some people, it was cumbersome, they might be static, out of date, you don't know where they are, it's impossible to have an ideal one. And then many of you said, well, it's all very well, even with a really good care plan, when the crisis happens, it all falls apart and everyone calls the LAS, and all the best wishes go down the pan when there's unexpected or unpleasant symptoms. But despite all that, all the groups who discussed it felt we need one. So the question was, who is this care plan for? Obviously the patient and the relatives, the professionals involved, but when it comes to so many people, they have different perspectives, and can that care plan reflect those different perspectives? And are we aware of our perspectives when we put them on a care plan? Some of you wanted different sections for different users, so an out-of-hours care plan, an out-of-hours and emergency care plan, a family care plan. But all of you said this care plan must be endorsed by patients and their relatives. What should be in it? Well, obvious things like patient demographics, who's involved, key family and friends, details of attorneys. And interestingly, you said also who not to contact, because there are issues of consent here when you're sharing patient information. Patients might not want certain people to be contacted. You wanted a holistic care plan that gave you an understanding of this person as a human being, so including social aspects and very importantly their cultural and religious aspects. And you wanted a functional description of their problems, as well as the basic clinical data, drugs, preferred pharmacies. Now, then it was a matter of deciding about management plans and goals, and not just vague goals, but goals if the condition worsens, so which involves having a conversation about what if. Aspects about discussions on DNAR, ceilings of care, and preferred places of care and death. And I'm really impressed with the Warrington story to go from 26% to 86%. I'm sure Barnet can do that. And it should be a record of what the patient wants and their understanding of their condition. A lot of it was about anticipatory care, and the thing that caused most of you sort of worries and anxieties were when unexpected or unpleasant symptoms happen. So preferably to record what fears the patients have, what trade-offs they might make, and what they would find acceptable or unacceptable. If possible, what to do in a crisis, and numbers to contact out of hours. Certainly what to do out of hours was a big problem for many of us. There was a form from a care plan model from a company called Respect, and they had a pictorial aspect showing the gradation from proactive care, sustaining life, to more palliative care, which is prioritising comfort. And many of you thought an image like this was useful for patients to sort of look at and share where they are with you. Definitely you wanted it to be clear, short and simple, minimal bureaucracy and user-friendly, and we have someone from CMC coming to demonstrate whether that's possible, and be compatible with your existing IT systems. It needed to be a living document and flexible, not set in stone, because as we all know, people change their minds. And when it's updated, you need to be able to change, let all the professionals involved know about that. Before you could even do this care plan, inevitably you need a trusting relationship. And there were issues about having conversations, sensitive conversations around end-of-life care and DNAR. Some of you thought these should be routine conversations for our chronically sick patients, a bit like NHS health checks, because after all, we're all going to die and maybe we all have some views we want to record. And better do that with a familiar doctor than the poor old foundation doctor in A&E who's having to have these sensitive discussions. And then there was issues around who has this conversation. We have heard stories about A&E doctors having the conversations, specialists, oncologists, renal physicians, GPs. Sometimes the professionals are not always singing from the same hymn sheet, and that can be challenging for the patient. So, agreement on what the goals and priorities are across the professionals. It's very challenging if someone in the hospital is doing very active treatment and the community are doing more palliative or comfort-based treatment. Looking at how to manage patients' and families' expectations and areas of disagreement, knowing who to share it with. And these conversations possibly are more important than the plan, but it would be good to document. In terms of collaborative working, duplication was a big issue. Patients reported that they get frustrated having a DNAR conversation in hospital, then with the GP, then with the hospice. So if we could somehow find systems where one person has a meaningful conversation, we can carry it through from secondary through to primary care. Try to avoid conflicting messages, so professionals talk to each other about what their plans are. And there was mention of a CCG initiative called the Red Bag Initiative, where these details will be carried around with the patient. We've talked about discharge summaries being helpful for the community. So if a care plan's been drawn up in hospital, please let us know. And equally, if we've drawn up a care plan, could we please let our colleagues in the hospital know? Many of you wanted to create opportunities for key professionals to meet more, particularly GPs and district nurses. And generally speaking, there was an overwhelming voice that we need more district nurses. These are our colleagues who do the bulk of the care and carry the can and are there in an emergency. And we really value you, and we think we need more of you, if anyone's here from the commissioners. Also, our receptionist colleagues, pharmacists, they need to know when someone's has palliative care. So consistency is important, availability, and identifying a lead. The resources you identified were, of course, training, and I'm hoping CPEN will listen to what the training requirements are and see what we can do to fulfill that. And that's about skills like conversations as well as practical management issues for end of life. Obviously, it takes time to have these conversations, so we would need to prioritise who we can do these care plans for, because we can't do them for everyone. And I've put in bold, increased district nurse provision, because that was just a resounding voice from all the MCLGs. Some of you would like a website that collates all the resources, even an app, and to integrate it with IT systems. So that's your views. They're not the views of the CPN. This is what came out of the group. That's a summary, and you've all got a copy at your tables for you to discuss later on. Thank you.
Thanks very much.